Okay, good morning, everybody. As you heard, we are having technical difficulties that we're working on, but I thought I may as well just get started and acknowledge that we are respectfully located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. So we are back in classroom D, and we have been, I guess this will be our third or fourth rounds. It's the end of February, which is, I don't know how it goes so quickly, but there you have it. So today's speaker, Dr. Winnie Sia, is a general internist who's been here since 2000 and is an obstetric medicine internist, having completed her obstetric medicine fellowship training at Brown University in the US. She's professor at the University of Alberta and has clinical and research interests in preeclampsia, thrombosis, and long-term vascular health. She's currently the director of obstetric medicine and the Royal Alex Hospital site chief, which I know keeps her very busy, for the Department of Medicine. So I think we are on our way here with the slides, so I will hand it over to Winnie.
Well, good morning, everyone. It brings me a lot of pleasure to be in this room here. I'm a local and I train here, and this room brings back a lot of memory, and it's always nice to come across the river to see familiar faces. And so today my topic, because I work at the Alex and for my obstetric medicine, is pregnancy complications and long-term maternal health.
Is it online? But we can't see it in the room yet.
That's what we could just mention that so people online know what's going on.
Okay, yeah. And and why the pregnancy complications and long-term maternal health would be cardiologists, neurologists, and everybody's business. And heard that there's also an emergency physician here, so I will also name drop that. So apparently we are still having technical difficulty such that my slides are not projected on the screen, but the Zoom participants, you are able to view them. So how much longer should I continue or?
I think just keep going, and what I would suggest is if people want, we can send you the link and you can at least follow the slides until we get them going in the room.
Okay, so this is like a test. It's like those MMI that I need to like describe the charts and things, and so, but we'll just keep going here until we get the slides. It's good. No. Okay, so I have no conflicts of interest. And so the three objectives I have today, the first is that to recognize that preeclampsia, preterm delivery, and adverse obstetrical outcomes increase long-term maternal vascular complications. And secondly is to be aware of some of the proposed pathophysiology and also some of the proven pathophysiology that may associate pregnancy complications with long-term maternal risks.
Maybe we'll just ask as people are signing on, just make sure your audio is off so we don't have the echo, and we'll continue working on this. Sorry about this, people.
And lastly, to review some of the potential change that I'm hoping that we can incorporate in clinical practice, having the knowledge that is going to be described. So I'm going to start with the case. Is that so in emergency room, actually 38-year-old woman presents with shortness of breath in the emergency department. And her shortness of breath is associated with occasional chest pain and is exertional. But she's otherwise healthy. She's 38. And on exam that her blood pressure is borderline at 140/90. And she thinks that, it's from white coat hypertension. And the rest of the exam is unremarkable. You can argue that maybe she shouldn't have to go to emergency room, but anyway, this is a made up. And family history is that her father has type 2 diabetes and her mother has hypertension. So what's your pretest probability that this dyspnea and chest pain is cardiac in origin? Probably a 38-year-old, otherwise healthy, you're like, this is nothing. But what further history may be helpful in this case? Okay, this is where it gets to be a little tricky. That, I think some of you may have access to online to the slides, which I have a forest plot. I have a lot of, should I just continue or describe or? We have been working on this. Sorry for the Zoom participants. It's just that the slides are still not projected.
Yeah, what we'll do is we'll put the laptop there so the people who don't have to really see that.
It's right up here, it's a little higher.
Yeah.
Okay, so maybe if you can't see, then it's a good time to move closer. There are seats here that's closer. Okay, so in 2007, this was a UK systematic review and meta-analysis from Dave Williams' group, and so that had like over 3,000 citations showing that preeclampsia, which in the research definition would be the hypertension, proteinuria, but as you know, could affect a number of other organs and also fetal effects. So that preeclampsia increases the risk of fatal and non-fatal ischemic heart disease in later life in these women, and with a relative risk of about 2. And that's the relative risk increases with the severity of preeclampsia and also with the degree of preterm. The earlier the preeclampsia happened, then also the relative risk is much higher in the systematic review and the meta-analysis. It's as high as almost 8. So this is another study that by Sarah McDonald in Hamilton at the time that showed that the risk of cardiac disease later in life is increases with the severity of preeclampsia. So hopefully I've shown you that that preeclampsia is the cardiologist business. And what was astounding from Joel Ray's study in 2005 in the Lancet, he's an obstetric internist in Toronto, is that he used the Ontario administrative database and found that the first cardiovascular event after an index pregnancy with preeclampsia is only 10 years. And so at the age of 38, a pregnant a woman still in childbearing age could have their first cardiovascular event. And so who would think of a 38-year-old patient having a cardiovascular event? So I think this is pretty shocking to a lot of people when they found that out. And so this review in 2018 by Karen Ehrenberg, who some of you may know, is an obstetric internist who worked in Edmonton for a few years and now is in Calgary. So she has a really nice depiction that shows that hypertensive disorder in pregnancy, HDP, which includes preeclampsia, HELP syndrome, eclampsia, and gestational hypertension, for instance, it increases the cardiac complications such as coronary heart disease, atrial arrhythmia, heart failure, and cardiovascular death by a relative risk of 2. So it gives you twice as high of a risk of having these problems. And of course, with chronic hypertension, all-cause death. So with all that, so that hypertensive disorders in pregnancy is cardiologist, general internist, business. And so, but not only that, also hypertensive disorder of pregnancy increases the risk of stroke. So it's also the neurologist business. And so this depiction outlines some short-term complications, but more long-term consequences going along with what I'm discussing here in terms of the neurological long-term consequences, such as both ischemic and hemorrhagic stroke, and cervical artery dissection, cerebral vein thrombosis, and vascular dementia. And that the preeclampsia increases the risk of both fatal and non-fatal stroke, again, with a relative risk of about 2. And also, preeclampsia increases a long-term venous thromboembolism risk in these women with similar relative risk. And so this is preeclampsia is also hematologist business. So I'm trying to, as my title suggests, that preeclampsia and adverse pregnancy outcomes is everybody's business. And so, and this is actually a Canadian study that used the discharge abstract database, looking at hypertensive disorders in pregnancy and subsequent risk of end-stage renal disease. And that eclampsia, not surprisingly, increases the long-term ESRD risk, and that preeclampsia imposed on pre-existing hypertension increased that much higher, with that incidence rate being significantly higher. And the next one, this is showing the probability of having no ESRD hospitalization. This is for ESRD hospitalization. And so just to depict that, the same information showing that the preeclampsia, eclampsia really is the worst. The red line is the worst in terms of causing or associated with ESRD hospitalization. So this was actually a Scandinavian population health database back in 2001. And so this sort of started this whole thing and has a really nice Kaplan-Meier curve, which I like. So in the yellow dotted line here, if you can see for the audience, by the way, in the room is looking at a little small laptop screen because that's in the front. And so that the survival curve is worse for those who had preeclampsia and preterm delivery. So preeclampsia is bad, and but adding preterm delivery really compounds on the long-term risks. And so hopefully I've discussed that preeclampsia, is one of the pregnancy complications that is a problem for long term. But now I'm bringing up a second adverse pregnancy outcome, which is preterm delivery. So for out of a 40-week full gestation, preterm delivery being defined as less than 37 weeks, actually by itself is actually a problem in terms of causing decreased survival. And so this is preterm delivery even without preeclampsia. So that's very interesting. That there's so many factors that may go into preterm delivery, but that in itself can also cause a decreased survival. And so this systematic review and meta-analysis back in 2018 was looking at preterm delivery itself and without preeclampsia and long-term maternal cardiovascular disease, and also found that preterm delivery increased the risk of coronary heart disease death, and stroke by about 1.5 to 2 in terms of the risk ratio. So just preterm delivery itself. So you may ask, okay, well, when does these incidents would happen after a delivery? So this study actually breaks down into time frame. And so within less than 10 years after the delivery of preeclampsia, of preterm delivery, there's already an increased risk of coronary heart disease. And between 10 to 30 years after the delivery of a preterm delivery, you will see even a higher risk of cardiovascular disease, and also cardiovascular disease death, and also stroke, with the hazard or the risk ratio of about 1.8 or so. So meaning that even really the first 10 years after a very young woman of a preterm delivery, there could already be cardiovascular health complications, and going a little bit forward, even just after 10 years, but less than 30 years. And we're talking like this is still, women at 50 or 60 years old, they could have increased risk of stroke. And so that's still, relatively young for between that 10 to 30 year time frame post delivery. And so this part broke down the degree of preterm delivery. So between to less than 32 weeks, and also 32 to 37 weeks. So preterm or severely preterm for the less than 32 weeks. And that is showing a dose response curve in terms of how early that. And so the less than 32 week, the preterm delivery is associated with a higher risk ratio for the coronary artery disease, and also CVD death and stroke compared to just preterm. So less than 32 weeks is definitely a red flag, a big red flag in terms of a risk marker. So this is another study that was a very interesting design that looked at the Swedish, the national database from across several decades, and showing that preterm delivery increases the risk of long-term stroke in women, and they also actually had a co-sibling design. And so I won't go into that part, but again, proving that a very preterm delivery, and this one is between 22 to 27 weeks, had a a much higher hazard ratio of causing stroke in the long term. So this is just some fancy numbers and spine curves showing that. So hopefully I have shown you some data that the preterm delivery and is also the cardiologist business and the neurologist business, and that the severe preterm, the degree also confers a higher risk long term. So it's not only preeclampsia that is a problem, but preterm delivery. Okay, no hope of this being projected on the screen. Okay, all right, sorry. Okay, so what other adverse pregnancy outcome, that is something that is also worth mentioning. There's a number of others, but I just showed the last one here, which is low birth weight. And so low birth weight is defined in most studies as less than 2.5 kilograms. So that's about 5.5 pounds. And so that also increases the risk of the mother's long-term coronary artery disease risk with an effect estimate of about 6.5. So these are all concerning. And so so that low birth weight is also cardiologist business here. I don't know if there's any cardiologist, but maybe in the background here. Oh, there's something in the chat. Oh, yeah, okay. So hopefully I have shown you and hopefully convinced you that adverse pregnancy outcomes such as preeclampsia or gestational hypertension, preterm delivery, and low birth weight are early identifiers for long-term heart disease, stroke, chronic kidney disease, and death in these patients. So you're thinking, okay, well, that is kind of weird. How does a condition that lasts for less than 9 months could have such long-lasting effects? So let's talk about start with the pathophysiology of preeclampsia. So, in this slide here on the left side is non-pregnant diagram showing the 3 layers, the myometrium on the top. The middle is the endometrium with all the little squiggly thing, which I'll describe as a spiral artery. And then the bottom is the lumen of the uterus, and that's where the implantation goes in. And so in non-pregnant situation, you would have in the across that red line here. I'm describing a little bit more because of the classroom audience here, they can't see my cursor. And so across the red in the myometrium is the arcuate artery, and then kind of vertically projecting down is the radial artery, and then it forms a spiral artery in the endometrium and sort of down towards the side of the lumen of the uterus. So in normal pregnancy, what happens is from the side of the uterus in the bottom here, and so there's the trophoblast from the fetus. And so that the trophoblast lineage, and so there's the syncytial trophoblast, and so which is sort of it's hard to see for the in classroom audience, which is the like a little yellow cells lining the side of the spiral artery, and so it would go and invade the syncytial trophoblast would go and invade the uterus, and then cause the spiral artery remodeling to be a bit bigger, and such that the syncytial trophoblast becomes the barrier between the maternal blood flow and the fetal capillaries. And so that the problem with preeclampsia in the right side panel here is that there is a abnormal remodeling of the spiral artery, so that you can see that it is not as big in terms of the size. And so there's actually decrease in the factors that are secreted to the trophoblast function. And so that the spiral artery remodeling abnormality causes placental ischemia, so that there is actually less flow going into the villi. And this the placental ischemia as a result of the abnormal spiral artery development, remodeling, as a result, cause a big imbalance of the anti-angiogenic and the angiogenic factors, so that it increases the anti-angiogenic factor called sFlt, which is the soluble FMS-like tyrosine kinase, and but decrease the vascular growth factor, so decrease the amount of VEGF, so the vascular endothelial growth factor, and decrease the placental growth factor. And so the imbalance of the having the higher anti-angiogenic factors, the sFlt, and less of the VEGF and the placental growth factor, as a result, cause endothelial dysfunction. And the endothelial dysfunction can affect different organs, such as all the vascular muscle tone with the hypertension, and also in the kidney with hypertension, proteinuria, edema in the liver with the endothelial dysfunction causing hepatic ischemia, and also activating the coagulation system, and then causing the cerebral edema as well. So that's why preeclampsia affects so many organs through the biomarkers. And again, there's a dose response curve in the sense that the more severe the preeclampsia there is, and then the more of the imbalance, so the more of the anti-angiogenic factor, the higher level of the S-FLIT. And so with the darker graph with the severe preeclampsia, in the left side here is the S-FLIT compared to the middle gray one, which is the mild preeclampsia. So severe shows a higher level of the S-FLIT level. And so with the angiogenic factors, which is decreased in preeclampsia, so that had less of the VEGF and less of the placental growth factor in this dark, the black bars compared to the gray bars, which is the mild preeclampsia. So interestingly, if we look at how high these levels of the S-FLIT and the placental growth factor is at the time of the index pregnancy, and so this study then asked 12 years later these women to say, "Hey, can we study you?" We had data. This is a Swedish or Spanish study, I think, Spanish maybe. So that they had their serum, they had their blood from 12 years ago. And so now 12 years later, and to say, hey, can we study you and see how you're doing now? And so looking at their angiogenic factor and actually trying to see what happens to them 12 years later. And so interestingly, if we look at the level of the gestational placental growth factor, so that's the angiogenic factor, which is decreased in preeclampsia. And so those women 12 years later had higher blood pressure compared to they have a group of control as well who had uncomplicated pregnancies and also asked them to participate 12 years later. So compared to the uncomplicated pregnancies, so that the blood pressure in the preeclamptic women 12 years later was higher, especially with lower level, the lower the level of the placental growth factor it was initially. The index pregnancy. So similarly, the placental growth factor had, if it was lower in preeclampsia, so 12 years later, so those women had a lower HDL. So this is also endocrinologist business in terms of preeclampsia and long-term cardiovascular health. And so again, the placental growth factor, the lower it was, then actually when the study looked at the echocardiographic finding of the global longitudinal strain, which I think if the cardiologist can correct me, but I was, so my understanding is this actually predicts the future LV function. And so that the less of the shortening or the strain is worse. And so that is associated with lower PLGF. So that the worse of the preeclampsia with less of the PLGF, the placental growth factor, is associated 12 years later with worse LV function by the way of global longitudinal strain. And so they also looked at the carotid intima and media thickness, to predict a stroke risk. And similarly, the lower the placental growth factor level predicted that 12 years later, that there was a thicker carotid intima and media thickness, so compared to uncomplicated pregnancies. So these are all very good data to show the link between biomarkers that happen in preeclampsia and longer term outcome. Okay, so I'm seeing in the chat, Mahua saying that most important specialists here may be endocrinologists. Yes, of course, Mahua. And so, the table of this longitudinal study, or retrospectively anyway, showed that I talked about the placental growth factor. And so what about the S-FLIT? So S-FLIT, as you recall, is the anti-angiogenic factor. So unfortunately, in preeclampsia, we have too much of that. And so that having too much 12 years later is associated with worse HDL. So yes, Mahua, this is your endocrinologist problem. And so worse ApoA, and but also cardiologist problem because it's the higher of the anti-angiogenic factor S-FLIT at the time of the index pregnancy 12 years later, in addition to the longitudinal global strain and all that, also increase the LV posterior wall thickness. And also this we know that from the PLGF data, but increases the carotid intima media thickness as well. So let's see. So we know that, I think we know that preeclampsia increases long-term. Yeah, so actually, sorry, this is the baseline data of that. It's the same study. I'm doing a little bit of a reverse. Is that, yeah, these are the women. So that at the time of the preeclampsia 12 years ago, they had very high blood pressure. Their blood pressure was 170 over 110 compared to uncomplicated pregnancies of 114 over 62. So, and they delivered early as well, 33 weeks versus 40 weeks. And their birth weight, baby's birth weight was 1,400 grams versus 3,100 grams. So these are the triple whammies that I talked about: the gestational hypertension, the preterm delivery, and also the low birth weight. So the triple whammy, so in this population, and that they followed 12 years later. And so, and sure enough, we're finding some harder data in terms of, what's causing the long-term vascular or metabolic complications. So this is basically saying the same thing. And so the women who had preeclampsia back in the days 12 years ago, now 12 years later has a higher waist circumference, even though I think it didn't really show in the body mass index. And so, and a higher incidence of dyslipidemia. So again, it is definitely also endocrinologist business. And so you may ask, how early do these vascular stiffness kind of happen after the, preeclampsia delivery? And so knowing that 12 years later, so so this is a study from Ottawa, and so maybe some of you know the authors here, and so called the EVA study, the early vascular aging. So this looked at recruited women at 6 months to I think 6 years postpartum with an average of about 2 years time. And so basically they did similar thing. They recruited 40 women with history of preeclampsia and had 40 age-matched control with normotensive pregnancy, and then did echo and look at their arterial tone and found that brachial and central blood pressure was higher in those who had preeclampsia. Aortic stiffness was worse, and there's increased steady arterial load, increased arterial waveforms. And so as early as 2 years, that these have already, changes have already been demonstrated, showing that there's early vascular aging, is saying. And so again, metabolically, at 2 years' time, it's already showing a difference between blood pressure, LDL, triglyceride level, hemoglobin level, and waist circumference that, in women who had preeclampsia versus those who had normotensive pregnancies. So these changes start pretty early, and then it lasts until at least 12 years, and we know that actually longer from the epidemiologic data. So this is just another study looking at the carotid artery thickness. This is a 7-year follow-up and showing very similar results. And so in 23 preeclampsia women, and compared to normal, that there is an increased thickness of the carotid intima and media thickness in those who had preeclampsia, persisting 7 years after. So these are all kind of not very good news for women who had hypertension in the pregnancy. So hopefully I have, kind of convinced you that, first of all, as I discussed already, that adverse pregnancy outcomes such as preeclampsia or gestational hypertension, preterm delivery, low birth weight, increased long-term cardiovascular risk. But what is sort of the intermediate, like the pathophysiology? So it is through increased hypertension, increased risk of metabolic syndrome, and this increased vascular stiffness, and increase of the LV, the wall and mass, and then the carotid artery wall thickness. And through all that to result in the heart outcomes of CVD, stroke, CKD, and death. So you're saying, Winnie, so okay, fine. Now what? Knowing that there's a history of preterm preeclampsia with low birth weight, so what can we do about it? So I do know that there is a big knowledge translation gap currently on this topic. And so a few years back, and that I did a survey of physician knowledge in the Edmonton zone with the medical student, Jocelyn, and to see what's going on with in the groups of family physicians, obstetricians, general internists, obstetric internists, and cardiologists. And in terms of who's asking about pregnancy complications when you see a patient, who's doing counseling on increased risk of cardiovascular risk, who's doing counseling in women who had a history of preeclampsia to reduce their cardiovascular risk, and who's following up these people, these patients regarding the cardiovascular risk. So thanks if you have responded to the survey, thank you. It's of course has a very low response rate, but I think, for what it's worth, and so this is quite interesting. And so I think that in terms of asking about pregnancy complications in the general history, the family physicians and obstetricians do the best at about 3/4 of the time. And so general internists do it about half the time. And obstetric internists, that's our job. If we don't ask it, we're in trouble. And so for the 4 cardiologists who replied, they don't actually ask about pregnancy complications in general history. So I really hope that after today, if you're listening, that this would be something that you would incorporate in your clinical practice, is that you ask about pregnancy complications. And so in the survey, looking at who actually counseled on increased risk of cardiovascular risk, again, there's a lot of room for improvement in pretty well across the board. Family physicians, obstetricians, cardiologists, and so in terms of following up, then we're not doing a great job. It's only less than half of the practitioners are following up these patients for long-term for cardiovascular risk. So here, since 2010, I have a postpartum vascular risk reduction clinic called Postpartum Preeclampsia Clinic. So that's sort of the orange mark. So this is sort of a regional referral pathway for postpartum patients who had preeclampsia. And so then they kind of get followed up perhaps to obstetric medicine. So that, we're the internists who have an interest in training in obstetric medicine, or else they kind of get seen, of course, by the obstetrician or family physician who practice obstetrics. And then they kind of go, so with my clinic, then they get referred to. And so, but I only see the high risk, I only see the preterm preeclampsia. for the postpartum follow-up and assessment and counseling. And so otherwise they would go to the family physicians, and then, you know, if there's some potential complications that persist or that appear, then they would be referred to the general internist, hypertension, lipid specialist, cardiologist, nephrologist, endocrinologist maybe. And so, so I think that my hope is that that more of the family physicians would take on this responsibility to follow these patients long term, because I don't suspect that let's say cardiologists, general internists, or nephrologists and endocrinologists have a special clinic to do that. And I have actually surveyed my patients who've attended the postpartum vascular risk clinic over 10 years time to see how they're doing. And so that overall there are fewer of them who attended the clinic compared to those who didn't, who developed hypertension. And there's a non-statistically significant trend of having less diabetes for those who attended the clinic. And what really warmed my heart was that more of them who attended the clinic follow up with the family physician about their vascular risk management, because I send the family docs a letter and kind of, you know, advise them on as to how to follow them and what to look for, check their LDL and, you know, do this and a few other things. So I think that we could, you know, have a practice change in terms of, number one, asking, you know, knowing that these people had a history of these adverse pregnancy outcomes, and secondly, counsel them on the risk. And even though if you may not be able to follow them, have them follow with their family physicians. And I think that such intervention actually may improve the follow-up and hopefully subsequently improve the clinical situation of these patients. So for the family physicians, it's a little, you know, kind of up in the air in terms of what they're supposed to do if they, you know, are not familiar with this topic, and because our guidelines are not very clear, they're very non-specific. And so I'm happy to report that our Canadian best practice guideline for prevention, screening and management of cardiovascular risk factors after hypertensive disorders of pregnancy is coming soon. And so it's sitting in CMAJ, and so hopefully it's been with them for a little bit. I think we're updating the literature search, and so in that guideline, which is more for family physician, and so that you know, we have a number of aspects, you know, for vascular risk reduction, for screening, for instance, for hypertension. So this is screening for the first 6 weeks after delivery, and for management of hypertension for the first 6 weeks, and then for screening beyond 6 months after delivery, and then for management beyond 6 months after delivery, for instance. And so this is not public yet, published yet. So, but it's a peek preview. Kara allowed me to share this. And so similarly for dyslipidemia, which is actually more of a contentious area, especially like what threshold do we want these women to be at for their LDL? And so Preeclampsia Foundation with a cardiologist, they suggest less than 2.6 for LDL. So we're saying less than 3.5. And so that's what I've been sort of, and so we kind of, you know, put ourselves out there for that. And so kidney disease. And we, in our field, we talk about pregnancy as a stress test. And so this is a nice depiction. I've shown it before in my previous talks. And so bear with me if you've seen this before. So going across the x-axis is time, right? And so, and then in the y-axis, I'm just describing more for the classroom audience. The y-axis is increasing risk, vascular risk factors. And so in the horizontal dotted line, the black is sort of the vascular threshold. So if you go above that, then you will show up for clinical manifestation. So I'll just walk through the red line and then describe that more. So the red line is basically people who are genotypically susceptible to vascular manifestations and risk. and versus the blue dotted line, which is below, which is the healthy population. So if you follow the red line, and so, they're going through life after birth, and so it's still sitting well below the vascular risk threshold. And then, but if you have a pregnancy, bang, so then you have a bump. And so pregnancy, with all the physiologic changes and the demand on the body, in those who are genotypically susceptible to develop vascular complications, will go up and show up with gestational hypertension, preeclampsia, gestational diabetes, postpartum thyroiditis, and all that. And then after the delivery, then it comes down to be quiet again. Oh, okay, you don't need the blood pressure medications anymore. Great. Oh, you don't have diabetes anymore. Great. And so you think that they're great. Well, they're, coming down, yes, but at a higher baseline level. And so again, until let's say they have another pregnancy and then bang, they have these go up with their vascular risk manifestations and vascular complications, I should say, or metabolic complications. And then again, after the delivery, then they go down, but again at a higher baseline level. And then later on, that they would actually show up go above that horizontal dotted line to show up to develop, let's say, coronary heart disease that we saw in epidemiologic studies way earlier than the blue dotted line people who are the genotypically normal, the healthy population. So my goal is that, and what my preeclampsia clinic, postpartum preeclampsia clinic is trying to do is in that time, the early window and opportunity is that we can have early intervention. And so this is like, there's no other condition or population that actually would kind of give you that window of opportunity and tell you that, hey, I'm about to get these complications. This is a very unique population that allows us to do something. So I think this is a golden opportunity. And so if you don't have, let's say, a clinic that may follow them for long term, and so I'm hoping that if you see them later on, at the time that they are showing up with shortness of breath, chest pain, TIA symptoms, like early pronuria, that we are able to diagnose them early and not to delay the diagnosis. And so, that would be my hope if you do more like acute medicine and that type of practice, is to not kind of delay the diagnosis because they're young. And so now going back to the case, which was a 38-year-old woman who presents with shortness of breath in the emergency department. And so she's got some borderline hypertension. And so her father has some, the diabetes, and mother has hypertension. So that I asked before, what is your pretest probability that this dyspnea chest pain is cardiac in origin? I mean, and what further history may be helpful? So I guess I'm trying to sell pregnancy history here, right? And so then hopefully that you will always remember if it's a female patient, and so childbearing age or not, that ask them, have you ever been pregnant before? And if so, did you ever have any pregnancy complications, such as high blood pressure or delivering early before your due date or having a small baby? So I'm making this case up to say that, yeah, okay, she had high blood pressure at 32 weeks and delivered at 34 weeks for preeclampsia. Her baby was on the small side, weighing 4 pounds, and she needed blood pressure medications for 6 weeks after. So again, this is the triple whammy. And so this is a very high risk patient to develop long-term vascular risk. So even at 38 years old with shortness of breath and chest pain, of course, maybe I'm going to argue that maybe you want to be a little bit more aggressive in terms of your assessment and maybe management. So the Canadian Cardiovascular Society back in 2016 acknowledged that hypertensive diseases of pregnancy is a cardiovascular risk factor that you would screen these patients on for for dyslipidemia. And so this is following the American Heart Association a few years before that to acknowledge that hypertensive disorders of pregnancy is a real independent risk factor that could cause cardiovascular risk. So this one I got from Up to Date because I'm thinking, okay, well, what could we do? What could you do, in your practice that can incorporate this knowledge? So we always ask if we worry about someone, whether they develop some cardiovascular, cerebrovascular conditions. We're like, okay, do you have diabetes? Do you smoke? Do you have family history of early premature cardiovascular disease? Do you have kidney disease? I would argue that it is equally, and if not more important, if for female patients who had pregnancies before, to also ask, did you have preeclampsia, preterm delivery, IUGR, and or intrauterine growth restriction, or meaning like low birth weight, or stillbirth, placental abruption? So this has to be part of your standard cardiovascular risk factor history. So I think that we are a little bit behind in terms of incorporating this as a risk factor, as a standard sort of, training. And so if you go down this up-to-date kind of risk stratification, then of course, there's, of course, Framingham would not apply to this population. And so, it's saying that for age 30 to 79 years old, you assess your 10 years, atherosclerotic, the CVD risk and all that. So we don't really have a risk prediction score that incorporates the adverse pregnancy outcomes yet. So it's, I think a lot of groups are trying to work on that, and locally we're trying to work on that as well. And so, but I would argue until then that you, in your mind, that you increase that pretest probability, and so not treat women who had these pregnancy outcomes the same way as what is in the traditional, gender non-specific kind of prediction score. So I'm coming to the end here, and so my question to you is, now knowing that adverse pregnancy outcomes with someone who could have, suspected, symptoms that could be cardiovascular disease, would you actually be more aggressive to investigate her? So that's actually a question that I don't know the answer, but I think that it's food for thought. And so, would you do more testing, and their symptoms may be a bit different. So yeah, because we know that heart disease is the number one cause of death in women. This is US data. So stroke is number 4 on that list, and diabetes, kidney disease, hypertension is number 8, 9, and 10 in that top 10 list. So these are all very important conditions that if we could have a crystal ball, and basically we're given a crystal ball to see who is going to develop these, then we should do something, in that early intervention. And so this is Canadian data, which actually lists Alzheimer's disease and other dementias as a top cause of death. But beyond that, the ischemic heart disease is there, stroke is there, and kidney disease is there in the top 10 cause of death in female. So to summarize, my first objective today was to have to recognize that preeclampsia, preterm delivery, adverse obstetrical outcomes, which I highlighted as the low birth weight, increased long-term maternal vascular complications. And so these are the triple whammy that I said that would do that. And these actually are the early identifiers for long-term heart disease, stroke, chronic disease, and death. And that to be aware of the pathophysiology that may associate the pregnancy complications with long-term maternal risk. And so through having increased metabolic syndrome, vascular stiffness, thicker LV mass, and carotid wall artery, as early as 2 years, and then 7 years, 12 years. And so really it's in the continuum, but starting really early, which explains why a lot of the the clinical manifestations can happen within less than 10 years time after an index delivery. And to review potential change in clinical practice that incorporates this knowledge. So remember that hypertensive disease pregnancy is a cardiovascular risk factor. And that, so I hope that you will remember to ask your female patient who have been pregnant, their pregnancy history, and if there's any complications to actually raise your clinical suspicion for these vascular management that you don't normally remember too. And that I think with all that, that we can make a difference in the long-term outcomes of these patients. Thank you.
That was a really wonderful talk, Winnie, and especially with the challenges that you were facing. Thank you so much, and my sincere apologies for that. We don't have a lot of time for questions, but I just wanted to step back a little bit and ask you about, I'm still a little unclear on cause and effect. You alluded to genotype and sort of individuals that are predisposed to pregnancy-related hypertension, but do we know, sort of genotypically or even epigenetically, the types of patients that would be predisposed to hypertension in pregnancy? And if so, is pregnancy a stress, or is it just a marker that, these are the folks that are going to run into trouble later, so keep an eye on them? Or would they have run into trouble at earlier ages regardless of pregnancy?
Yeah, so Norman, you asked a very good question. That's always it's really hard question to answer, but it's a really good question. So I think probably the Zoom participants would have
Hopefully they heard that.
Yeah, so I think my best answer right now is actually that the Swedish administrative national database for preterm delivery and long-term stroke. So in that, I mentioned that it was a co-sibling design. So they specifically identify out of that big cohort over a few decades time, about 1 million women who delivered, who had sisters. And then they looked to see if, that the genetic or environmental factors would, increase, like the sisters who didn't have preeclampsia, right? Or who didn't have preterm delivery in this case, would have increased risk of stroke, and they didn't. So it's not the same genetics, of course, not like twins. And so I think that probably maybe the best study to say that it's not the genotype itself. And I know that I showed you the depiction of the genotypically susceptible, but I think the pregnancy itself, with all the anti-angiogenic and the angiogenic factors added on, that the physiologic stress that cause long-term endothelial dysfunction in those genotypically susceptible. And so it's both a genetic, and so then it's additional. So if these are the pregnancy, the complications, I would argue would be the additional markers that that these patients, if they didn't have pregnancy, that would not be they would not have such endothelial dysfunction. Yeah.
Really interesting. There's the questions in the Q&A, I think you've mostly addressed. And I'll just, because we're out of time, I'll just ask folks, if you have any questions, Winnie's available, and I know she's very passionate about this topic, so come and talk to her or reach out to her or what have you, and she'd be more than happy to answer your questions, I'm sure. I'm speaking on your behalf, Winnie. I hope that's okay.
Yeah, of course.
So thank you so much for really a very eye-opening rounds.
Thank you. Thanks, everyone.